explicitly address stigma among people with mental health conditions in our work with them in treatment. We work on symptom management and recovering lost functioning, but we don't think about stigma as it is a form of trauma. And so this presentation is really a summary of how I've started to think about how stigma could be conceptualized as a form of trauma itself. And then also making recommendations for considering it when working with folks, and also addressing it. So how do we change that? How do we address stigma as a form of trauma? Let's see, there we go. Okay, so I'm gonna briefly go over what I mean by stigma when I'm using the term stigma. So I'll define it for you. And then I'll tell you a bit about how it impacts people living with mental health conditions. I'm sure that a definition of trauma is kind of gonna be a little bit something that you already know about, but I'll define trauma so that you know how I'm using the term. And then I'll look at some existing literature that supports conceptualizing stigma as a form of trauma. And then finally, I'll talk about ways that we can address stigma in a trauma-informed manner. So this is what is called the Stigma Types by Constructs Matrix that I developed in 2014 along with my colleague Patrick Corrigan at the Illinois Institute of Technology. And what this matrix does is it breaks down the 4 different types of stigma by the 3 different constructs that comprise the stigma process. So stigma is a social cognitive phenomenon. It's actually a process whereby our stereotypes, the beliefs that we hold about a stigmatized group, give rise to emotional reactions, which are called prejudice. And these emotional reactions then lead to behavioral reactions, which are discrimination. So there's actually lots of different types of stigma, but there's 4 main types of stigma that we commonly talk about in the literature. One of them is public stigma. So that's how the general public views people with mental illness, reacts to them emotionally, and behaves towards people with mental illness. And when I say the general public, not everybody stigmatizes, but a substantial portion of the population does endorse stereotypes, the corresponding prejudice, and behaves in discriminatory ways. Self-stigma is when somebody with a mental health condition internalizes the stigma themselves, resulting in a loss of self-esteem or self-efficacy. Label avoidance is when people avoid people or places that might prime the label of mental illness and therefore subject them to stigma and discrimination. And then structural stigma, sometimes the camera gets a little bit in the way, but I think you can probably see that it says structural there. Structural stigma is when stigma makes its way into law or legislation. So I'm going to go through an example of each of these to kind of flesh this out a bit. So for public stigma, the stereotype might be people with mental illness are dangerous. And if we believe anything is dangerous, a person or a place, we tend to have an emotional reaction of fear. So people with mental illness are dangerous. I'm afraid of people with mental illness. And then the discriminatory response might be, and this is an example in an employment setting where we see people with mental illness commonly face discrimination. I will not hire people with mental illness. I need to look out for my safety and that of my other employees. So for self-stigma, another common stereotype is that of incompetence. People with mental illness are incompetent is the stereotype. The prejudice in this case is how the individual reacts to that stereotype, the individual living with the mental health condition. So all people with mental illness are worthless employees. I have a mental illness and therefore I'd make a bad employee. And this leads to a discriminatory response or a behavior that we call the why try effect. Why try seeking a job? I wouldn't be able to succeed at it anyway. So this is this loss of self-esteem or self-efficacy as a result of internalizing stigma. And it's worth noting here that not everybody with a mental illness self-stigmatizes. In fact, research suggests that about 1/3 of people with serious mental illnesses internalize stigma. And the reason for this is they must undergo a process where they're first aware of the stereotypes that exist. And when I talk about this, I always say that I'm going to present some imagery to you later on in the presentation, you'd have to essentially live under a rock not to be aware of stigma. It's really all around us. Where people might vary, though, is this agreement piece. So you could be aware of stigmatizing cognitions or stereotypes about mental illness, but you might not agree with them. And if you don't, then you might not internalize stigma. Also, in terms of application, some people living with a mental health condition either don't identify as living with a mental illness, or they have a sense of pride regarding that identity. So if they don't view themselves as part of the group, they won't self-stigmatize. And then the result here, as I mentioned, is the hurt caused by self-stigma, or the why-try effect. One thing I forgot to mention earlier is when it comes to public stigma, and to a large degree structural stigma as well, and I guess we could apply this to self-stigma, advocates agree that it's really important to address stereotypes and to address prejudice. But what really, really matters is preventing discrimination. So preventing unequal treatment of people with mental health conditions. Label avoidance, the example might be people with mental illness are crazy. We've probably heard that term thrown around before. The prejudicial response here might be all people with mental illness are crazy, and I'm afraid to be labeled as crazy. So this might be somebody who's not yet engaged with mental health care, but they think they might be experiencing some symptoms. And then the behavior is, I'm not going to be seen walking into that mental health clinic. That way, no one will think I'm crazy. For me, this is a very, very concerning, and a lot of my work has looked at this. Nikki mentioned in the introduction that I've done quite a bit of work in the post-secondary settings with college students. And I found that this label avoidance is a big predictor of avoidance of treatment. And what is most concerning to me is the longer somebody goes without treatment, on average, it's like a 10-year gap between the onset of symptoms and treatment participation or engagement, the more likely they are to develop a significant disability as a result, worsening symptoms. So there's a lot of negative outcomes that come from label avoidance. And then structural stigma is when, as I mentioned, stigma makes its way into law or legislation. So the example here is people with mental illness have control over their mental illness, whereas people with breast cancer do not. I just chose another form of physical illness that is less stigmatized. And this piece here of control is another common stereotype surrounding mental illness. And there's actually two types of control beliefs. So we tend to believe that people with mental illness are in control of the onset of their mental health condition. So somehow they did something, they put themselves in situations, whatever the belief is, that caused them to develop a mental health condition. The other control belief is offset control. So we tend to believe that they're responsible for their illness and the onset, but that they don't have control over their own recovery or the offset. The prejudicial response here might be people with mental illness are to blame. So blame is the prejudicial response for their mental illness and don't deserve the same coverage as people with cancer. And then the resulting discrimination here is lack of mental health parity. Now, in the US, we've made strides towards achieving parity, but there's still quite some work to be done. And a lack of mental health parity is discriminatory towards people with mental health conditions. And I will say, if there's any questions or comments, please feel free to interrupt me. I know that Nikki set aside some time at the end on the agenda for questions and discussion, but I'm totally open to interruptions as well. Okay, so just to summarize, the common stereotypes include dangerousness, the belief that people with mental illness are unpredictable or violent, responsibility, blame and shame, onset control and offset control, and then incompetence. And these stereotypes lead to fear, anger, and pity, which lead to discrimination. So how do we see discrimination manifest? Well, it's one of the greatest barriers individuals with mental health conditions face in achieving their life goals. We see it in employment settings. So there's been many instances of refusal to hire people living with mental health conditions. And also we see individuals with mental illness in lower level jobs with fewer opportunities for advancement. There's quite a bit of literature documenting the impact of stigma and discrimination in participation in post-secondary education. And for example, the work that Mark Salzer at Temple University has done has shown that students who feel like they're stigmatized in their post-secondary setting are less likely to complete their college degree, which is a huge labor market liability. And then we see it manifest as social isolation. People with mental illness who experience discrimination in mental health treatment settings, and also I mentioned that construct of label avoidance, where people are less likely to utilize mental health services if they feel that they need to avoid that label. We see it in as a barrier to physical health care as well. So for example, there's been research that has presented physicians with two identical clinical profiles that would suggest that somebody needs treatment for a heart condition. And the individual that's labeled with the mental health condition is far less likely to get the appropriate referral to care as compared to somebody without that label. Stigma thwarts recovery and it worsens distress. That happens in a lot of different ways. I mentioned how label avoidance can prolong the course of an illness, for example, but also, for example, self-stigma in terms of serving as a barrier to recovery. If that why try effect plays out, why try participating in evidence-based mental health treatment? It wouldn't help me anyway. And that's where recovery is stalled by stigma. So if we think about it this way, one of the ultimate negative consequences of stigma is suicide. And so there's been some work that's been done in Europe. This particular research looked at individuals in high and low suicide rate regions. Belgium versus the Netherlands, so neighboring countries. And in the Netherlands, there are low suicide rates and more positive attitudes towards help seeking, less shame for seeking help, and lower self-stigma regarding help seeking. In Belgium, where there are high suicide rates, there are poorer attitudes towards help seeking, more shame for seeking help, and higher self-stigma regarding help seeking. Again, a European study, this was looking at 25 different European nations, and it used data from an instrument called the Eurobarometer that measures social attitudes in these European countries, and compared it with data from the Eurostat, which has suicide rates and also other demographics. And what they found was that in the regions with the higher suicide rates, there is lower social acceptance towards people with mental illness. This looks like a little bit of a mess, but I'm going to animate it for you so it's a little bit easier to look at. So this research was looking at suicidal ideation among young people at risk for psychosis. And what's important to note when looking at this figure is that this is controlling for age, gender, and positive and negative symptoms. So those are all risk factors for suicide among this particular population. And they were interested in seeing how self-labeling and the stress related to stigma predict suicidal ideation after controlling for those other demographic risk factors. And what they found was self-labeling was significantly positively related to suicidal ideation. So that self-stigma process is playing out here. Self-labeling led to social isolation, which then, by way of social isolation, increased risk for suicidal ideation. Stigma-related stress led to greater social isolation, which led to lower self-esteem, greater depression, and greater suicidal ideation. So the take-home message here is that these two predictors, self-labeling and stigma stress, contribute either, well, in all cases, actually, indirectly through social isolation, self-esteem, and depression to suicidal ideation among these young people who are at risk for psychosis. And then the final study that really highlights the connection between stigma and suicide is this one that looked at the relationship between stereotype awareness, so that first piece in the self-stigma model, for example, and self-esteem among people who had and had not attempted suicide. So in this figure, the solid line are people who had no past suicide attempts, and the dotted line are people who had a past suicide attempt. So you can see that for those with no past suicide attempt, the line is parallel to the bottom axis, right, to the x-axis. So there's no relationship between stereotype awareness and self-esteem for those folks. For the people who had a past suicide attempt, however, high stereotype awareness was significantly related with lower self-esteem scores. So what this research is showing that awareness of these stereotypes by way of lowered self-esteem for those people who had had a suicide attempt might have put them at risk for suicide. Okay, so now moving beyond talking about stigma and its consequences to looking at how trauma comes in here. So this is the definition that I am using in this work, and I'm open to different definitions if anybody has suggestions for trauma. So individual trauma results from an event, series of events, or set of circumstances experienced by an individual as physically or emotionally harmful or life-threatening, with lasting adverse effects on the individual's functioning and mental, physical, social, emotional, and spiritual well-being. So that definition is from SAMHSA. So when I've been thinking about stigma as trauma, this reference that I have here to Gates 2019 is actually from a book talking about stigma and autism spectrum disorder. And but I think it's really powerful, and when I was looking for resources on stigma as a form of trauma, this is the one reference that really popped out to me. So Gates talks about what's called identity fatigue, which is a form of complex trauma involving chronic assaults on the fullness of our humanity. I'm going to present you with some imagery in a little bit that's going to kind of reinforce this idea of chronic assaults on the fullness of our humanity. It results from repeated stigma, judgment, rejection, and or prejudice. So those constructs that I showed you earlier contribute to identity fatigue. Because of qualities inherent to our personhood, qualities we may not be able to change or may not have chosen. This chronic invalidation builds up traces of shame in so many of the narratives coming from people with mental illness. Shame is such a huge part of the narrative. And I think part of the work that we need to do as advocates, as clinicians, is to try to address that shame experience. So people become heightened, have a heightened awareness of the fact that they're being judged by others in their community. And they spend a whole lot of energy doing environmental scans to see if they're in a safe place. Or they might be set to default to expect stigmatizing or reactions or discrimination just because of this chronic assault that they've had on their humanity. So there's the traditional view of the relationship between stigma and trauma. And this is what I would say is the traditional way that we think of the relationship between, in this case, trauma and mental illness. So we'll start there. We know based on, adverse childhood experiences, for example, that trauma can result in mental health conditions. And that people with mental illness are also oftentimes find themselves in situations where they're they can experience trauma. So we know that people with serious mental illness are more likely to live in high crime neighborhoods, for example. And so you can see how that would be a kind of two-way reciprocal relationship. We might say that if somebody is labeled as having had trauma experiences or being a trauma survivor, that by way of that label, they might experience some stigma. And then I've presented to you some data suggesting that mental illness, the label, can lead to stigma. So what happens here is, in order to initiate the stigma process, we need to label somebody. That could either just be by hearing a diagnosis, or it could be by seeing some of the behaviors that might come along with specific mental health conditions like schizophrenia, where there might be some outward indicators that the person is experiencing symptoms. And then this kind of trips off the stigma process. We associate stereotypes with that label, whether it's trauma or mental illness. The prejudice comes into play, and then the resulting discrimination. As I've been thinking through this conceptualization of stigma as trauma, this is how I've been thinking about it. So we know that mental illness leads to stigma. And now I'm proposing that stigma is itself a source of trauma. So we talked about the reciprocal relationship between trauma and mental illness. And if we really look at this in its totality, this is kind of a unidirectional process whereby trauma leads to mental illness leads to stigma leads to trauma, and the reverse. I feel that we do a lot of work to address trauma, and we do a lot of work to address mental illness, but that we don't really address stigma as part of this kind of triadic relationship. So I'm going to present to you to help us to really understand how traumatic stigmatizing representations of mental illness can be. I'm going to present to you some images, and I just want to issue a content warning that, to me, these are really disturbing. I think they're necessary for us to see and to address, but just practice care as I'm going through these next few slides. So in this example, we see mental illness stigma in headlines, so in news headlines. So on July 10th of 2002, there was a fire at Trenton State Hospital. We're probably all familiar with state hospital settings. People with serious mental illness oftentimes receive treatment in these settings. So what was the local newspaper headline the next day? Roasted nuts. So I close my eyes whenever I think about this and imagine being either the person in the state hospital setting living with a mental health condition, or a family member or a friend, and seeing this headline and how disrespectful this is, how just completely unacceptable. But this is a newspaper. People see this, and this is part of that chronic assault on the identity. We see it in advertising. So although mental illness and suicide are related but different issues, we know that I think it's something like 90% of people who die by suicide have a diagnosable mental health condition. So we can make this leap here. So this is Career Builder, a big company, and they thought that this would be clever advertising. So imagine being somebody who has a mental health condition, maybe somebody who's experiencing suicidal ideation, looking down to see this top of the bus, don't jump. Another one that is related to suicide, the picture's blurry because this is a very old example, but I think it's so powerful, I continue to leave it in my slide decks. So this is a storefront of a printing business. And what this business did is, you can see the imagery here of the legs in the top view of top or half of the image. And what you can't probably read next to the tipped over chair is it says, contemplating suicide, get your suicide notes printed here. So again, this is chronic assaults on the identity of people living with mental health conditions or with suicidal ideation. Here's an example in another example in advertising. This is I'm sorry to say, donut chain. So there's more than one of these in California called Psycho Donuts. They're crazy good is the tagline. Here we have an image kind of reminiscent of Nurse Ratched from One Flew Over the Cuckoo's Nest. And the text reads, "A trip to Psycho Donuts is a sensory experience designed to bring out the crazy in all of us." So again, that use of stigmatizing language like crazy. Psycho nurses are on hand to provide bubble wrap therapy to minimize your selection anxiety. So bubble wrap therapy, minimizing the power of psychotherapy to help people with mental health conditions in their recovery. And then also selection anxiety, minimizing the incredibly debilitating experience that can come along with anxiety disorders. Probably the worst part of this for me is this is a picture of the Psycho Donuts padded cell. So a photo op, if you go into these establishments, is to have your picture taken in this. I don't even know where to start here, right? For those of us who have worked in or experienced an inpatient hospitalization or worked in that setting, we know that these rooms do exist, and they're there for very extreme circumstances when people are incredibly agitated and need to be kept safe. But the experience of using a padded cell is incredibly traumatic. It's the most restrictive type of intervention that can be delivered. And so just the fact that this is being used as a photo op, somebody seeing this who's living with a mental health condition, another chronic assault on their humanity. So there is some little, which is why I'm doing this work, is there's little research that supports this conceptualization of stigma as trauma, but there is some that exists, and I hope in the future to be able to contribute to a growing body of literature here. This is an article that was published in the journal Stigma and Health. These are researchers from Boston University, from the Center for Psychiatric Rehabilitation. So, this center is really, really well known for their amazing work in psych rehab and recovery and understanding stigma. So this article talks about the use of a research methodology called photo voice, where, and I'm not an expert in photo voice, though I really think it's a really cool tool. Essentially, researchers give cameras to the research participants. So in this case, it was people living with mental illness, and they asked them to use those cameras to document their experiences. In this case, they asked folks to document their experience of stigma. And I find this so powerful. I asked Nikki before we started today if we could distribute these slides if people are interested. And she was open to that. So we can send along this slide deck if it's something that you'd like access to. And in the notes of these slides, you'll see that sometimes there's like a video link. We chose not to share a video today because it wasn't working on my computer. It wasn't worth the hassle. But there is a video that they've done on this photo voice project that is so incredibly powerful. It's also 10 minutes long, so I didn't know if we would have time today. Here is one example, though, that I think it's featured in the video, but it's certainly, this is what I took from the article. So this is a trash can that one of the participants took a picture of. And then they provide a narrative to explain what this picture means to them. So this individual said, "Some people don't understand mental illness. They think we are trash. We are locked up, thrown away, hidden like trash. When people treat us like trash, it discounts our courageous behaviors. Our positive recovery should shed light on the stigma of mental illness." So just to view oneself, view others as thinking of you as trash, in my opinion, has to be traumatic. They include a table in their article that looks at both so this is their qualitative analysis of the narratives and the imagery that the participants took, or provided pictures of, I should say. And they split this out into symbolic visual representations of stigma and then the negative impact of stigma. So I'm going to make this I'm blowing this up for you a little bit. So some of what they pulled out were metaphors. So we just talked about trash as a metaphor, dirty barrels, litter in an alley, judging a book by its cover, a doll in a trash can. So just some examples highlighting just the shame and the, really awful emotions that must come along with thinking that your community views you in these ways. And then if we look, so I'll go to the next slide. If we look at some of the negative impact, I mean, here it's really highlighted in black and white, literally, right? The emotional impact, anxiety, fear, sadness, pain, shame, loneliness, a lot of the same emotions that I think probably come along with the experience of trauma. And then impact on the identity, being ignored, being judged, silenced, rejected, feeling devalued. So all of these things, again, going back to that chronic assault on one's sense of humanity. So, the stigma exists. People are going to face these stigmatizing images. So what can we do to help with this? And I would advocate for addressing mental illness through trauma-informed care. I'm not an expert in trauma-informed care myself, though I do really like the approach. And I'm really interested in partnering people who have expertise in this area. I know enough to be able to understand that it seems like it would be a good fit for this issue of addressing stigma as trauma. So again, I'm going to provide some definitions, which I'm sure many of you are familiar with. This one talks about being trauma-informed as understanding how violence and victimization have figured in the lives of most consumers of mental health, substance use, and other services, and applying that understanding and providing services and designing service systems so that they accommodate the needs and vulnerabilities of trauma survivors and facilitate client participation and treatment. With regard to this service, designing service systems, I actually believe that our move towards a recovery-oriented system of care is aligned with addressing stigma as a form of trauma. A lot of the approaches that come along with recovery orientation would do that. Like, for example, the integration of peers into service settings. But making sure that we are always thinking about the stigma that folks may have experienced as a result of their identity as a person with a mental illness in service delivery, I think is really important. So this is a table from an article by Butler and colleagues, I believe. I have two references there. I think it's the Butler and colleagues article, addressing mental illness stigma through trauma-informed care. And so they list out principles of trauma-informed services that I think are highly aligned with addressing stigma as trauma. So recognizing the impact of violence and victimization on the development of coping strategies. I teach a course in our major called Recovery-Oriented Mental Health Services. And one of the, I honestly think it's one of the most powerful things that I share with those students is Pat Deegan. In case anybody's not familiar with Pat Deegan, she is a psychiatrist who is a woman living with schizophrenia. And she was diagnosed in, her, I think, teens, early 20s maybe, and basically told, go on Social Security, you're never going to be able to work, you probably won't live independently. And she internalized that stigma pretty significantly for quite a period of time, but then went on to become a psychiatrist and a mental health advocate. And she wrote a really powerful piece, if you've never had the opportunity to read it, called Recovery as a Journey of the Heart. It's the first thing I have these students read as part of this course. And what she talks about in that article is what's called hard-heartedness. And this is as a result of the chronic assault to your humanity that you experience when you experience all of this stigma. People become hard-hearted. It's a coping strategy, as in this first bullet. It's a mechanism that people have developed to deal with this. And so what it manifests as to an outside observer is, oh, they just don't care. They don't want to participate in services. Most likely untrue. It's just that this has been a coping strategy. to help them to deal with the fact that they've been, continuously discriminated against or stigmatized across the course of their experience with their illness. Identify recovery from trauma as the primary goal. So I think the thing I argue for most strongly is, again, as I mentioned, as I started out this presentation, we don't really talk explicitly about stigma in the lives of people living with mental health conditions within treatment settings. And I think that we need to. Empowerment, employing empowerment model. Empowerment is conceptualized as actually being on the opposite end of the continuum to self-stigma. And so this makes a lot of sense to me, is the more empowering you are in your work with people living with mental health conditions, the more likely it will be to reduce that experience of self-stigma. Client choice is a big part of recovery orientation as well. And then, so there's more on this list, but I think those first few bullet points are really important as we talk about addressing stigma as a form of trauma. So there are recommended treatments, which I'm sure you all know of, for treating trauma, specifically PTSD. So there's a set of treatments that are strongly recommended by the American Psychological Association, and then some that are conditionally recommended just based on the amount of evidence that's accumulated. So cognitive behavioral therapy, I'm sure we're all familiar with different versions of cognitive therapy, like cognitive processing, and then exposure therapy, prolonged exposure therapy. There's also those conditionally recommended, like brief eclectic psychotherapy, EMDR, or eye movement desensitization and reprocessing, narrative exposure therapy, and medications. And the ones that I've highlighted in red, I did so because there are existing anti-stigma programs that adopt these strategies that I think could be useful in clinical settings. Referrals could be made to these programs to help deal with stigma as a form of trauma, I believe. So narrative enhancement and cognitive therapy, or NECT, is a, I believe, 10-session intervention led by a clinician, and it's divided into different components. The first is psychoeducation. It's understanding what is stigma. So kind of like what I did at the beginning of this presentation. The next is cognitive restructuring. So participants are taught strategies for identifying some of the negative thought patterns that have resulted from stigma and refuting those negative thoughts. So they're taught really practical strategies, which some people who have background in CBT might be familiar with. Like one is called be a detective. What's the evidence that you're incompetent because you live with a mental health condition? And then you help them to come up with examples of achievements that they've had. And that helps to refute those negative stereotypes. And then the narrative enhancement therapy comes at the end, where once they've done this cognitive restructuring, they then start to re-story. So they're telling their story from a strengths-based perspective now, and this helps with reducing self-stigma. There's actually quite a bit of accumulated evidence for the effectiveness of this intervention. Honest, Open, Proud is a program. I've actually been involved with NEC. One of the co-creators of NEC, Phil Yanos, is a mentor of mine. And then Honest, Open, Proud is a program I've been involved with. I was involved with developing part of the program when I was in graduate school. It started out being called Coming Out Proud, because we were taking a lot of what we've learned from the LGBTQ plus community and applying it to people with mental illness, because both groups have concealable stigmatized identities. Interestingly, I mean, talk about stigma, the LGBTQ plus community didn't want us, using that terminology because they didn't want to be grouped with people with mental illness. And then some people with mental illness were saying, well, we're not members of the LGBTQ plus community. And so if we renamed it so that people would actually engage with the program, because it's just the name, right? So Honest, Open, Proud is a disclosure-based stigma reduction program. I mentioned this idea of concealable stigmatized identities. When you have a concealable stigmatized identity, you have the ability to choose whether or not you share with people that you have this mental health condition, or that you identify, for example, as LGBTQ+. And with mental health conditions, this program starts again with a bit of psychoeducation. What is stigma? It then, and what is disclosure? Like, how do we think about disclosure? And then it helps people to weigh the pros and cons of disclosure, to talk about different settings that they could disclose in, different people that they might disclose to, how to test people out to see if they're safe disclosure partners. I actually have a grant that's currently under review with the National Institute on Disability, Independent Living, and Rehabilitation Research to do Honest, Open, Proud with USF students with mental health conditions. The final part of this program is now that we've weighed the pros and cons, you've made a decision about who you want to disclose to, or if you want to disclose, let's craft your stories. So sometimes, because people have been unheard for so long, their story just comes out and it's not really, it doesn't have like a coherent message to it. And so there's like a worksheet in the manual for this intervention that helps people to decide exactly what pieces of their story are important to share, and think about what goal they're trying to achieve through disclosure. It's important to note, this is a reviewer criticism of my grant proposal that I addressed in my revision. It's important to note that the goal here is not to convince people to disclose. Because, I mean, I presented you with all that stigmatizing imagery. There's some stuff I cut out of this presentation that if I would love to share it at a later date, that, you know, research that shows just how much we endorse these stereotypes. So people do, stigma's real, discrimination happens. We certainly don't want to be, you know, encouraging people or convincing them, coercing them to disclose. The process, though, of actually making that decision for oneself instead of being closeted because of stigma is empowering. And so I truly believe that programs like Honest, Open, and Proud, by empowering people to make those choices for themselves, even if the choice is not to disclose, can help to reduce self-stigma. And there's an accumulating body of evidence that suggests that Honest, Open, and Proud significantly reduces internalized stigma. Finally, there's a program called This Is My Brave that I have worked with for the past 6 years. Their tagline is "Storytelling Saves Lives." So I serve as the lead evaluator for this program. They are a theater-based stigma change program, and they're based in contact. So research suggests that the most powerful form of stigma change is contact, or sharing stories of living with mental illness, of stigma, of experiences of discrimination, but also what's really important is also of recovery. So they adopt a V-shaped storytelling format where there's kind of this on the way down message, like these are the struggles I've had, and then the on the way up message is how have I been able to achieve recovery. They do this, This Is My Brave does this, as maybe the logo suggests, through creative expression. So pre-COVID, they travel from city to city across the US and also in Australia. And they issue a casting call within the community for people living with mental health conditions to come forward and tell their story live on stage through monologue, poetry, song. You know, there's some people who've done dance. I went to the college edition in Boston, the college edition show right before COVID hit, actually. And somebody had like a whiteboard up there that they were like drawing on and telling their story. So it's just very creative. We've, through our evaluation partnership, done a couple of studies, a pilot study, which is on the left here, and then an online randomized controlled trial of the program, illustrating that it's effective. So the left-hand side here is the results of the pilot. In the pilot, we found that from pre to post survey, so we surveyed people before they watched the show to after. We surveyed the audience members, sorry, not the storytellers in this case. And there was a significant reduction in stigma. So what does that tell me? That maybe if somebody's experiencing a mental health condition and they're feeling this trauma as a result of all of the stereotypes, prejudice, and discrimination, that hearing these stories of recovery might be helpful to them. We also saw a significant increase in the belief that people with mental illness are capable of recovery, and a significant improvement in willingness to seek treatment, or help, I should say, because there's also, there's formal kind of treatment services and then other types of services. There's one other thing I want to, so I mentioned this is a survey of the audience. We have lots and lots of different research projects going on with This Is My Brave right now. But one of them we call the storyteller study. And we're actually looking at the impact of telling stories on the storytellers themselves. And I'm going to show you some preliminary data on that on the next slide. And then on the right-hand side here, in the RCT, the randomized controlled trial, we compared This Is My Brave to a comparison storytelling condition. So, which was like a series of videos. Jen Marshall, who's the co-founder and executive director of This Is My Brave, is a woman living with a mental health condition herself. So she told her story in a more straightforward fashion, and as opposed to the creative means. We were trying to see, excuse me, if that creative expression piece had an effect. And then we had a controlled condition, which was like a video unrelated to mental illness. I think it was on like virtual reality. And what we found was that desired social distance from people with mental illness was significantly decreased in both This Is My Brave and the comparison condition, not in the control condition. So we didn't find a difference between This Is My Brave and comparison in this case. Or actually, I'm sorry, let me correct myself. We did find a difference. The comparison condition had greater effect on desired social distance, but This Is My Brave had a significant effect. So desired social distance is a proxy of discrimination. It's really hard to measure discrimination. There are some creative methodologies that allow you to do this. Sorry, I got distracted because I was worried that maybe there were questions in the chat, but I see that that was just people saying that they would like the slides, and I'm really happy to share those with you. So since it's really hard to measure actual behaviors, we measure it with a social distance scale. And so an example item on this scale is, how willing would you be to have a person with a mental illness as a coworker? Marry into your family is another one. Care for your children is another one. So the greater your desired social distance, or the less willing you are to do those things, that's a proxy of discrimination. And then finally, perceived difference. So research suggests that we are more stigmatizing and more willing to discriminate against people that we view as unlike ourselves. And this comes from work by some researchers named Link and Phelan in an area called modified labeling theory. And basically they talk about how stigma comes about as a result of a process where the beginning part is separation of us versus them. So those people versus me. So the more different we perceive people with mental illness to be from ourselves, the more willing we are to stigmatize against them. So what we found here is perceived difference from people with mental illness was significantly reduced in the This Is My Brave condition, but not in the comparison and control condition. So something about seeing those storytellers through creative means tell their story live on stage. Now they're doing it virtually. They did This Is My Brave stories from home. Something about it reduces perceived difference, and that could have a really huge impact on stigma. And then finally, I mentioned the storyteller study that we're doing, or the cast member study. And what we've found is that in telling one story live on stage, and this is a choice, it's not going to be for everyone, but for the people who do this, there's a significant increase in empowerment before they're cast and after they share their story in a live This Is My Brave performance. I should have mentioned when I was describing the program that there's usually 8 to 10 cast members. And so they have like about a 5-minute segment where they tell their story on stage. There's a significant increase in self-esteem and self-efficacy, and there's a significant increase in feelings of having power over one's own life. Which, if you think about trauma, right, one of the things that traumatizing experiences do is they make us feel powerless. And so storytelling, whether it's on a public stage like This Is My Brave, or maybe in a more private setting like in the Honest, Open, Proud or narrative enhancement and cognitive therapy groups, could be a really powerful tool to addressing trauma. There are targeted special editions of This Is My Brave as well. And I think this is important when we think about not only targeting interventions to different populations, but as you'll see, the most recent special edition that we've been working on is This Is My Brave Stories from the Black Community. And when we're looking at that population, we're talking about layered traumas. So the trauma of mental illness, but then also the trauma of living in our country as a Black American. So the first one I'm going to show you is Stories from the Black Community. There's just some statistics on this slide suggesting that this is an important program. So African American adults report poorer attitudes towards treatment seeking and more stigma than white counterparts. Perceived stigma is a significant predictor of suicide among college students of color, and stigma change programs should be targeted to communities that they are meant to impact. So myself and my colleague, Dr. Kaya Connor, got a grant from USF's Understanding in Blackness and Anti-Black Racism Initiative to do this work. It was incredible. These storytellers are amazing. And we're currently analyzing the data to see what the impact of these stories has been. We have a college edition show. I mentioned that's part of my area of interest is college mental health. And we have, which I'm so excited about, they're working on a high school edition right now. One of my doctoral students, Michelle Beekman, is actually evaluating the high school edition program. So this is, the earlier we can target this, the better. So just to conclude, I think I'm actually right on time, which is, I'm impressed with myself because sometimes I tend to run a little bit over. So I found this, it's actually like a blog post by this clinician and psychologist, Dr. Comas Diaz. And it was on a blog called Mad in America. And it talked about addressing race-based trauma. And I just saw so many parallels for how we could look at that for people with mental illness as well. So in this piece, she talks about cultural competence as important for addressing race-based trauma. And I was thinking about how would this look for people with mental health conditions? Well, the post was in a group called Mad in America, which is a Mad Pride group. So it always shocks my students when I tell them that there's groups out there that actually think about mental illness as an identity of which someone can have some pride, having, overcome some of the symptoms. Even sometimes people feel that the experience of mental illness makes them a more compassionate human being. So we can think about madness as a cultural identity. And as we're working with people, that's an example of cultural competence to think about that. She also talks about socio-political awareness. So awareness of how stigma works to preserve the status quo, and then increasing awareness of how this causes trauma, helping people to understand they might not be making the connection between the stigma that they've experienced in their community and how that's been traumatic to them. And I think, excuse me, clinicians that are working with people from the Black community in particular are really thinking about this more now. We know that experiences of discrimination this is ongoing, this is nothing new. But I think that we've become our awareness has been heightened about the importance of addressing it. And then when you think about this through the lens of mental illness, a a lot of this makes sense as well. So understanding how stigma and discrimination towards people with mental illness preserves the status quo, and heightening that awareness of how that could contribute to trauma. An example of an intervention that I'm working on right now is interventions to bolster stigma resistance. So right now, my research lab is doing a integrative review, which is a type of systematic review of the literature, looking at strategies that different communities with concealable stigmatized identities use to resist stigma. So I would view this as an early intervention strategy. And it's connected with this socio-political awareness because you're heightening people's awareness of how stigma is traumatizing and teaching skills to prevent that stigma from having those negative consequences for the individual. And then there's alternatives to treatment and therapy that are suggested in this piece, including social justice action or activism. So for example, there's a program, I'm also on the board of NAMI of Hillsborough County. I'm the chair of the Mental Health Advisory Committee. NAMI has a program called NAMI Smarts for Advocacy, which would be, and NAMI, if anybody's not familiar, is the National Alliance on Mental Illness, where people learn how to tell their stories to legislators in order to affect policy change. So it's an example of social justice action. And then finally, coalitions with other marginalized groups or individuals. And the clear parallel here in working with people with mental illness is in peer support, but also in programs that are meant to support solidarity, so pride programs. So that is all I have for you today. I'm going to stop sharing and come back to screen in case there's any questions or if there's any discussion that might unfold as a result of this. So thank you so much for listening.